Hello, and welcome to the Clinical Care Options Infectious Disease podcast. I'm your host, Jessica Adams. This episode features content from an educational webinar titled Strategies for Optimal HIV Treatment and Prevention, Answering the Questions on PrEP Persistence, featuring Dr. Darrell H and Dr. Kenric Ware. Dr. Tan is an associate professor in the Division of Infectious Diseases at University of Toronto and a clinician-scientist in the Division of Infectious Diseases at St. Michael's Hospital in Toronto, Canada. Dr. Ware is an associate professor in the Department of Pharmacy Practice at South University in Savannah, Georgia, and chairperson and pharmacist on the board of directors for the Joseph H. Neal Health Collaborative in Columbia, South Carolina. For the full online educational program, please visit the link in the show notes for this episode. Now let's get started and hear what Dr. Tan and Dr. Ware have to say.
Fantastic. Thanks so much, Jessica. It's a real pleasure to be here. To start us off, we wanted to introduce the concept of the PrEP cascade, or the continuum of care, which is a really important concept when we're thinking about PrEP persistence. So here's some data from Northern California, the Kaiser Permanente cohort, and a paper has looked at individuals who are linked to PrEP care over a nice long period, 2012 to 19, shown here. And what you can see is that the way that they've conceived the PrEP cascade, it said that not only does one need to be linked to PrEP care in order to benefit from it, but one also, of course, needs to actually receive a PrEP prescription, one needs to actually initiate PrEP, and then one needs to stay on PrEP or persist on PrEP for some time in order to really accrue the benefits of it. And what you can see is that at each step in that cascade, there's a drop-off, not surprisingly. Something like 12% in that first step don't even receive that first prescription. Most who get the prescription do start it, but then you can see a huge chunk of folks at some point over this lengthy follow-up period will stop PrEP, roughly half of them. Among those who discontinue, something like only 60% will restart. So it gives us a sense of how much there may be, churn and turnover and drop-off within the cascade. What's also really important to note is that from a health equity perspective, if we look at, who is dropping off at each of these points, that's not equitably distributed. We do notice that the authors tell us that Black patients were significantly less likely to actually be prescribed PrEP in that first step, somewhat less likely to start on PrEP, and then certainly more likely to discontinue PrEP over time. So really important to have an awareness of the differential way in which this can happen for our different patients, how structural racism and other forces are always at play. The authors also showed similar discrepancies for Latinx individuals as well. Now, it's not to say that everyone who discontinues PrEP and then restarts is necessarily, doing so inappropriately. A lot of the time, maybe that's a good thing that folks have the health literacy to identify when they need PrEP and when they don't. But certainly raises our awareness of the possibility that folks may not always be persisting on PrEP when it remains clinically indicated. Now, also by way of background, we thought we would present this flowchart from the American CDC guidelines that are really designed to help clinicians identify specific risk factors or characteristics that should prompt a discussion of PrEP at minimum, and in many cases specifically prompt a recommendation to start on PrEP. In the context of sexually active adults and adolescents, some of those risk factors include sex with an HIV positive partner who's got an unknown or known detectable HIV viral load or HIV-1 RNA, folks who may not always be using condoms when they have one or more partners of unknown HIV status, and then also when folks have had a bacterial STI in the preceding 6 months or so. And as we highlight in the top of this slide, really the minimum standard should be that information about PrEP should always be provided to folks when we know that they're sexually active. Now, also not shown on this slide, but also noted within the guidelines, is that people who inject drugs should also receive this information. And certainly evidence of sharing injection paraphernalia would be a clear clinical indication to recommend PrEP. But once again, anyone who is injecting drugs ought at minimum to be made aware of the presence of this highly safe and effective intervention. If we're going to prescribe PrEP, what are we actually going to prescribe? This slide summarizes the good news that there are many options now available to us in early 2023 and more of them coming down the pipeline. In this chart, we're looking at different risk groups or different key populations defined according to sex and gender identity, where the risk might be through sexual activity. Now, it's also in the footnote that, again, many of these regimens will also be appropriate for use in people who inject drugs, in whom sexual risk should also, of course, be assessed and considered. The first regimen that, of course, we have had lots of experience with now is daily oral tenofovir disoproxil fumarate, or TDF, with FTC, so abbreviated FTC-TDF here, which is approved and recommended for all populations. And then specifically for gay, bi, other men who have sex with men, trans women, heterosexual women, there can be the use off-label of that same medication, but used in an on-demand or 2-1-1 fashion based on more recent data. Similarly, there is FDA approval for a daily TAF FTC regimen, so that's tenofovir alafenamide with FTC, the kind of version 2.0 of that drug. And then most excitingly and most recently, we've had the availability emerge for long-acting injectable cabotegravir for all the populations listed here. In some parts of the world, there is yet another long-acting option, which is the dapivirine vaginal ring. It's not available in North America, but for those with a vagina, where that would be the risk of acquisition, that represents another exciting possible option. Important to also note that for those with a vagina, where that would be the risk of HIV acquisition, the 2-1-1 TDF-FTC and the daily TAF FTC would be not recommended. That would be off-label. So this last thing that I'll summarize before handing it over to my colleague Kenric speaks about some of the less desirable outcomes that can sometimes arise with some of the different PrEP options. And we've summarized it according to regimen in this table. I think we've all known for a long time that tenofovir disoproxil fumarate, or TDF, can sometimes be associated with some renal as well as bone effects. And specifically in the original PrEP trials comparing TDF to placebo, we did indeed see some drops in creatinine clearance, some drops in bone mineral densitometry at the hip and spine when comparing that drug to placebo. And don't have a lot of data on the same outcomes when that same drug is used in an on-demand fashion. We do know, encouragingly, that when we use FTC TAF, that those impacts really don't seem to be there to the same degree. And again, with long-acting CAB, the same thing. We really don't see renal effects. We wouldn't expect them to be there. Don't yet have data on bone effects, but this gives us a sense of how the regimens differ with respect to those adverse events. The final one I'll just touch on is, of course, changes in weight, which has, of course, been a hot topic in our field for some time now and is often an issue of concern to patients. And what's interesting here is a reminder that it's actually that tenofovir disoproxil fumarate, so TDF, has been pretty much across the board been associated with modestly less weight gain, even a little bit of weight, when compared not only to the comparator regimen, so that's FTC TAF in the Discover trial, or when compared against long-acting cabotegravir in the HBTN 083 to 084 trials, but even when compared to placebo in the original PrEP trials. And what I think that tells us, and the interpretation that many have, is that there may in fact be a little bit of a weight suppressive effect with that drug that doesn't exist with the newer options. Nevertheless, it's also helpful, and I found this helpful when counseling patients, to point out that even when we do see a modest difference between the groups with more weight gain in people who use FTC TAF or long-acting CAB, the magnitude of those differences is pretty modest. We're really talking about a 1 to maybe 1.2 kilogram difference between the arms, kind of 2.5 pounds after a year or two. And a lot of that increase really occurs during the first year, doesn't continue very much moving forward from there. So that might be helpful when counseling patients about what they can expect. And from here, I'll hand it over to Kenric.
Thanks so much, Darrell. Appreciate that. So looking at discontinuing PrEP, right? So we recognize that for one reason or another, as Dr. Tan discussed, patients may decide or clients may decide that, their risk, they may have self-awareness of their risks, or their likelihood of contracting HIV perhaps declines, right? And so someone says, well, at this point, I'm really thinking about stopping PrEP. So what are some of the things that come up when people actually determine whether or not they want to stop taking PrEP? Obviously, it's going to be a case-by-case basis. Life changes, whether the relationship status might have changed from when the other person actually started PrEP That's one big consideration that we see often. Someone perhaps entered the PrEP regimen arena with in a different relationship status than they're in currently. And so they, after self-assessing, may decide, I really could do without PrEP for right now, so I want to stop. Also, too, when we think about toxicities, so toxicities are interesting because typically patients may be taking other medications. So from a therapy perspective, sometimes the toxicities can be a bit confusing to patients. So sometimes people may attribute toxicities to one drug that may be actually due to another. And so we recognize that that's often a challenge. But patients may decide, or people may decide, that PrEP really is the culprit. And so perhaps they would rather stop. A key point, too, is that protection factor. So we're really looking at about a week and a half, roughly, after people stop taking PrEP when they're protected. So and when we say protection, we're talking about protection from the risk of seroconverting or not living with HIV to coming to live with HIV. So that's a really important point that we should emphasize, is that obviously it's going to be some protection, but the protection isn't going to last forever, obviously, which leads to our last point as far as number of new cases and of HIV actually occurring when people do stop PrEP. So that's perhaps somewhat of a function of people continuing to engage or carry on the same or a similar lifestyle that perhaps that they could have benefited from PrEP from in the beginning. Perhaps that's persisting. And so naturally, you could actually see why sometimes the HIV rates may go up. And as you're looking here at the bottom of the graph, it really kind of talks a little bit about people who were linked but not prescribed PrEP, prescribed and did not take PrEP, stopped and did not restart. And that's a key population there, because again, sometimes the way someone views their need for PrEP or their desire for PrEP may be different from what their lifestyles may indicate. And so you can see once people stop, sometimes it's a higher likelihood perhaps that they won't restart. So we really should spend a lot of time having those conversations, making sure people understand that the totality of their lifestyle and their behaviors, making sure that stopping is the best choice, because as you can see here, depicted graphically, when people stop, the likelihood of starting back is fairly low. Dr. Tan also mentioned about the citing addition to, I guess, the PrEP library. When we think about long-acting cabotegravir, this was recently approved. Again, this is the newer addition after our oral options of FTC TDF or FTC TAF, as Dr. Tan discussed. So, but again, there may be a chance where people decide over a period of time that they'd rather stop taking the long-acting option as well. So here, when we think of the long-acting option, really we're thinking after a series of kind of introduction steps or consecutive months, you really take this option every 2 months. And so when we think of when people are going to stop, naturally, if you're taking something every 2 months, it's going to stick around in the body a little bit longer. So this graph really kind of shows really the relationship between when we think about risk of resistance or HIV resistance and PrEP, or really discontinuing PrEP. You see the decline about the long duration of the declining levels of cabotegravir and the risk of resistance with HIV. So that relationship, and that's a key point for us to discuss with individuals, with consumers of the long-acting cabotegravir. Again, if a person decides to stop, we do want them to be mindful of the fact that there is some growing evidence that's showing a relationship, again, with the risk of resistance that may occur when discontinued. Another big consideration here is that there may be individuals who are looking to shift to the oral option. So when could that start? Could that, could be a host of reasons for that, why people may decide that, a daily option is more preferable now than an injectable option. So if that's the case, whether we're thinking of, again, our older option with FTC TDF or the one that came on a little bit later, FTC TAF, we're really thinking about a 2-month time frame where after that last injection of cabotegravir, where people can begin the oral option. So again, that's always a conversation around if people want to transition from the oral to the injectable or from the injectable to the oral. Again, these are some guidelines as far as because that long half-life or the amount of time that cabotegravir is going to remain in the system, this 2-month mark is a pretty good indicator of when people can start on the oral option. And actually, if someone decides to start on FPC TDF or FPC TAF, a lot of the conversation around those options that Dr. Tan discussed in a previous slide are some of our guiding principles, whether or not we would start someone or whether a person would elect to start on the FPC TDF or FPC TAF. We definitely want to continue to monitor quarterly to assess the PrEP needs. Counsel HIV testing is important. Naturally, we want to make sure people are retaining that HIV negative status, that people have not come to live with HIV. So the HIV testing is important. You also see here in a lot of practices, a lot of settings where people may also test for your sexually transmitted infections such as gonorrhea, chlamydia, syphilis. It's a really good opportunity to also to test for those as well. Although not pictured here, that is definitely a good opportunity for us to really be able to keep an eye on that. And actually, we'll look at different organ functionalities, whether we're looking at kidney function, liver function, other considerations around these particular options when people are looking to follow up. We definitely want to make sure we have a good handle on that as well. The PrEP pipeline just continues to enhance, and which is exciting as a pharmacist. It's extremely exciting to see where we are. I guess you could say where we've been and where we are and where we're going as far as the PrEP options. So again, this is an exciting opportunity for healthcare. And as a pharmacist by training, it's exciting to see the advancements that we're making in pre-exposure prophylaxis. So the slide says where we are here. A person prefers an injection, or if they prefer an oral option, we have those available. Dr. Tan spoke a little bit about how the vaginal ring available in other parts of the world hasn't made its way here to the United States, but people are still pretty optimistic about it. And at some point, perhaps it will be here. And even further down the road, which is really exciting when we start thinking about implants, when we're looking at antibodies, again, really novel ways to help people to not come to live with HIV. So it's a really exciting time in the HIV prevention landscape that we have these options. And as I'd like to discuss with our clients or even with students here at the pharmacy school where I work, is that what a great time to be a pharmacist, to be able to sort out these options for individuals, right? Because the key goal is to stop seroconversion or to stop HIV acquisition. So the questions will definitely pour in from our communities and from individuals looking to get on these options, like which one is best for me, which one is best for my situation, for my lifestyle. And I think that's to be a wonderful opportunity for us to be able to customize our recommendations. So again, if the pill doesn't work for you, let's try an injection. At some point, we may be able to try an implant. So again, just a very, very exciting time and really looking forward to what the future holds around PrEP. Another key consideration around PrEP is telehealth. So as we know, we've all experienced it, still experiencing it to a certain degree when we think about the COVID-19 pandemic and the impact that that's had on everyone and everything, obviously, but specifically centered more for the PrEP discussion when we're looking at the decline in PrEP initiation. As you can see over the period of time, so obviously we all recall that 2020 mark when things were really, really accelerating with the pandemic. Unfortunately, PrEP initiation started somewhat decelerate, which makes sense for a lot of different reasons why people perhaps weren't being initiated on PrEP. And it was unfortunate as well because naturally during the pandemic, people didn't stop having sex or continuing to engage in behaviors that they could benefit from PrEP. But we did see a decline there during that particular time frame. So really telehealth came to the forefront, probably arguably a little bit more featured than it's been in recent memory as far as how we really relied on telehealth and some of the things that we were able to do even around PrEP, whether we were looking at some clinics, even where a clinic that I was practicing at the time, we did virtual visits, and we were able to help people, walk people through HIV testing virtually and answer questions there. As you all recall, perhaps during that time when people weren't able to enter into certain facilities. So this was telehealth really came to the fore there. And as you see, some of the things that could occur through telehealth, obviously be phone-based, it could be web-based. One big consideration, and we encounter this quite a bit with some of our patient population, is that consistent access to internet connectivity. That's a huge key. Obviously, if we're thinking about anything that's web-based or web-based consult, we definitely want to make sure that people have that consistent internet access, because naturally that's a rate limited step to engaging in a web-based platform. So I alluded to, as far as HIV testing, sexually transmitted infection testing, other considerations that the guidelines would dictate that we actually keep an eye on. We were able to continue to keep an eye on those levels during the pandemic and going forward, in large part due to telehealth. The home specimen collection, again, being able to meet with people virtually, really talk them through the process of home specimen collection, how to mail it off, where to take it to. Those logistics are really important when we think about telehealth and really the success of it and the sustainability of telehealth. We want to make sure we're in a position to help navigate people through that process, because we talk about health literacy, but I've come to find out it's just literacy in general in certain areas and among certain populations is very low. So what we can do, anything we can do to help demystify that process would be helpful for our populations. So the key take-home point, right? So naturally, when we think about PrEP, or really medicine in general, but I guess PrEP in particular, it definitely decisions to remain on PrEP, to initiate PrEP, should be individualized. We want to make sure that we have as good as possible assessment of persons holistically, where a person is and whether or not PrEP would be beneficial and how long it will be beneficial moving forward. We talked some about some of the considerations, the timeframes of switching from one regimen to another, one formulation to another, whether we're going from FTC TDF to FTC TAF, whether we're moving on from oral options altogether, perhaps FTC TAF to cabotegravir. We definitely want to make sure that we understand that we're looking at data, we're looking at recommendations, some of the things that were discussed earlier around somewhat the strengths and the areas of improvement for some of these products. It's a clear distinction as far as when we think about the number of new cases or HIV incidents and that relationship with PrEP discontinuation. So I think that's one of the bigger points that we can help PrEP consumers to keep in mind. So again, it's not to, I guess, force or somewhat scare people, for lack of better words, of staying on PrEP, but it really is to help them to make the most informed decision possible. And by presenting that data, that it is pretty clear now that when people do stop taking PrEP, their risk for acquiring HIV does go up. Expanding PrEP options that can help facilitate PrEP adherence and persistence. So again, we talked some about not only the telehealth platforms, but you have other resources out there, that there are websites where you can actually look to see who is on, who offers PrEP, right? And not only who offers PrEP, but perhaps some of the support services they have in place to allow people to remain adherent. One of the big challenges too, obviously, would be some of the laboratory testing associated with the therapy that could be cost prohibitive in some cases for some individuals. So ensuring not only that we're looking into the therapy options, but the complementary things that come along with the therapy. So again, the laboratory testing, we definitely want to keep an eye on the HIV status, as I spoke to before, ensuring that people are not living with HIV, the sexually transmitted infections, keeping an eye on those. So again, those things in some settings may cause some financial strains for individuals. So having a good working knowledge of resources that people can tap into will help there as well. And definitely thinking about PrEP outside of the traditional healthcare settings. Telehealth, again, as I stated, kind of somewhat out of necessity, I really soared to the forefront with the pandemic, but a lot from those experiences. And, they really can carry us forward as we optimize telehealth use, right? So as we hopefully turn the corner from this particular pandemic, we can continue to gravitate or hold on to those lessons that we got from telehealth to optimize the experience going forward.
Great. So thank you to Dr. Ware and Dr. Tan for that excellent presentation. We've had a number of questions coming in from participants, so we will get to those. How confident are you both in your own practices that you are effectively providing PrEP support, and what are the challenges that you've faced in providing adherence and persistent support to your patients on PrEP?
Jessica, thanks for the question. I'll try to tackle it first. I think it's a really tough one, I'll be honest. I think I'd like to think that I'm doing my best, but I think it's a complex process. And as the data have shown us, there's actually a lot of churn that does happen, that folks do fall out of care for all kinds of reasons. We don't always know what those are if they don't come back to tell us. So sometimes that might be appropriate, but sometimes it might not be, what's ultimately best for preventing HIV in that individual. And so I can speak briefly about some of the strategies that I've thought about in terms of trying to retain folks in care and support them as best we can. Some of them just rely on some of the fundamentals that we've talked about already in the last half hour or so, really making sure that we've made a point of keeping all of our patients aware of all the PrEP options that are available to them. Of course, this changes over time, as new products get approved, as new science comes out. So having that conversation on an ongoing basis with every patient, it's a tall order, and it does make for, lengthier PrEP visits than just saying, everything's fine. But I think it's really important. And there are data that we haven't talked about today that show us that, akin to other fields, when you make folks, populations aware of a larger menu of options that are available to them, you do in fact see increases in the overall population level uptake. In other words, we do attract new potential users to an intervention like PrEP by the sheer fact of making more options available and letting people know about them. So I think that's one of the fundamentals. Another one is something that Kenric just spoke to a moment ago, which is about, making sure that we have an array of different formats for providing care, such as telehealth, such as, video link, telephone-based PrEP. And of course, as Kenric mentioned, COVID, forced a lot of those changes on us, which ultimately is, of course, one of the silver linings of the whole pandemic. For myself, you asked about what some of the biggest challenges are, and I'll admit that some of the biggest challenges are making sure that I'm able to continue to try to offer a variety of different appointment formats to suit different patients that I may be trying to serve within the constraints of, a rigid healthcare system, within the constraints that institutions may impose upon us as providers. I'm assigned a certain clinic time, but unfortunately that falls within very traditional work hours for folks. And that's not convenient for a bunch of other patients that we serve. Similarly, we do insist within this traditional medical model on having people, stick with a very specific appointment time, and whether that's in person or even by a remote technology, it does require a certain level of organization of one's life in order to make that work for everybody. And it doesn't always. So we've got to be creative and try our best within the constraints that are imposed on us to try to make PrEP available to the largest number of people possible. So those are some of the fundamentals. I'll maybe finish my answer by saying one or two more things, which is just about how to really, number one, build the relationship with every single patient. I think having trust in a provider, having a trust between a provider and a client or a patient is really fundamental to trying to keep them engaged. And there's a lot of the human elements, the art of medicine that I think falls into there. And then the last thing is just that we want to really be attentive to the factors that contribute to churn within the system. And here I think some of the literature about why folks who could benefit from PrEP don't always choose to, take the health system up on its offer of PrEP can be really helpful. One of the top reasons that we've seen in our own research and that of others is that folks sometimes do underestimate their risk for HIV, and that may happen even in the course of their receiving PrEP. They may say, you know what, I just don't think I need this anymore. Sometimes that's accurate, and that's great if they're empowered to make those sorts of decisions. But I've definitely had patients where, unfortunately, maybe because of a problem with health literacy or just not quite getting something that's a little complex about PrEP, maybe the 2-1-1 regimen, maybe the timing of different things that they're supposed to follow up with. Sometimes I've had folks just very explicitly not quite understand when PrEP was indicated and when PrEP wasn't indicated. And it reminds me that we need to be constantly exploring sexual activity, sexual behavior, sexual relationships with our patients, even those who we feel we may know pretty well, who've been in our care for a while, just to keep on top of those issues and help people make the best decisions for themselves to keep them engaged in the healthcare that they can benefit from.
Thank you, Dr. Tan, and thank you, Jessica, for that question. And I definitely echo a lot of the sentiments that Dr. Tan has brought forward. I think also too, as far as how we're doing, so admittedly, we have maybe more of the benefit of time than Dr. Tan spoke to, where we can sit down and kind of have some of those conversations with our clients about PrEP. So one of the ways that I contribute to our healthcare system where I am is we have support group where we have a series of conversations around different options. Now, naturally, as of late, PrEP has kind of been pushed aside because of COVID or MPOX or other considerations. But when we do talk about PrEP, one of the things we really look to do is really to refrain from making assumptions around who would benefit from one formulation or another. So there are some tendencies to say, well, if someone perhaps is not as adherent as they could be, that perhaps they wouldn't benefit as much from a longer acting option because perhaps they'll miss an appointment or some other considerations. So we really try to check that bias there and really do the best we can to really, as Dr. Tan spoke about, really having a conversation, building that trust, making people aware of the benefits of the different formulations that are out there, and helping people to arrive at the best decision that they can make for themselves. I think another challenge is social media, and we really tried to hit this head on. Is when I say social media, obviously the entity in and of itself isn't bad, but when you think about some of the information that's put up can be less than accurate, to say the least. And so we're really having some conversations, in-depth conversations with some of our clients around, well, about things that they've reviewed on social media about people who perhaps stopped PrEP and didn't get HIV, even though they continued to behave the same way. So I think we're really in a space where, and obviously that could be screen shared or screenshotted and shared to others. And so the misinformation can travel pretty quickly. So I think we've really tried to do the best job that we could to go through some of the questions people may have that they've seen online or that they perhaps from a relative or a close friend, and really not to, I guess, altogether invalidate what someone else is saying, but really try to help people understand that, hey, when you're looking at things in a social media space or in a virtual world, that may not always reflect reality. And so we want you to make the best decision for yourself and your health, and not be as influenced by things that are posted online, particularly things that really don't come too close to the truth. I recall a client saying, about an herbal product that would be a substitute for PrEP, that this person read about this product that would be safer and wouldn't cause as many problems because it was more of a natural consideration. So I think those things we're constantly up against, really helping people to understand things that, while they may be well-intended, can be very disruptive to their desire to remain HIV negative.
Okay, great. Thank you both. I know you had a couple of questions for each other. So if you want to go ahead and ask those. Dr. Tan, I know you had questions about the long-acting injectables.
Sure. Thanks, Jessica. I'd love to ask this because in my practice set in Canada, we unfortunately don't have access to long-acting cabotegravir yet as PrEP. It's certainly available as part of combination treatment. So in a context like you're in, Kenric, I'd love to hear about, broadly how it's going, but with respect to the conversation around persistence and finding the right PrEP option for folks, I'm curious to know whether, number one, folks are actually coming in asking for it, and is the predictive research bearing out in real life to show that having more options is drawing new people into the fold. That's number one. And maybe a related question is for those who do PrEP in the form of Cab-LA, but perhaps choose not to continue on it. Of course, there have been concerns around how you come off, and the recommendation is to keep folks engaged in care, perhaps if there is ongoing risk, of course, transition onto oral PrEP options so that we protect them from the resistance risk that you showed us earlier during the long PK tail of CAB-LA. And I'm curious to hear how that's perhaps been going from an implementation perspective, because it's not necessarily as easy as it may sound.
Okay, thanks so much, Darrell. Yeah, I can't say admittedly, at least in my corner of the world, so to speak, that we haven't had people coming in requesting it. I think we have some conversations, and they just some of it is raising awareness around PrEP in general, and then it's like, hey, I'm on a certain amount of medications already. I really don't want to add another medication that I'm taking. So that's kind of our segue into, well, we do have an option now where you actually don't have to take another pill, right? And so that's kind of been our prelude into discussing long-acting options. And interesting, you mentioned the treatment option that has long-acting cabotegravir with another agent, or rilpivirine. One of the considerations we've encountered is serodiscordant couples. And so I recall a person mentioned, well, perhaps I would consider long-acting PrEP. This person was not living with HIV. If my partner were on the long-acting treatment counterpart, long-acting treatment option being virally suppressed. So that's something that I hadn't considered prior to that, about how couples may be making decisions jointly about if the partner not living with HIV decides to engage in a longer-acting option, perhaps the partner living with HIV, maybe that will actually compel that person's decision to actually transition to a longer acting option. But we haven't really seen people asking for it ahead of time, but after some conversation, and then of course, obviously the conversation shifts to how much is it going to cost? What are some of the other considerations? Because naturally, once someone's on an oral option for a period of time, you kind of got to adjust it to, the cost structure, the testing parameters and all that. So really assessing some of those complementary factors like transportation, all those things is it going to be a reliable option for you to be able to come in and get this particular product every 2 months? How does that look from an employment perspective? So I think those factors are things that we're still working through. And to just the second part of your question, we really haven't, thankfully, endeavored into the discontinuations. So we're still really heavily, obviously, the oral option, really FTC TDF is really kind of predominating what our patient population is on. And some of that's probably people here on the call may know it, with that being generically available and maybe more of a cost-friendly option for individuals. So we haven't really seen the discontinuation aspect, but we have asked people to let us know if this is something that you're thinking about, perhaps discontinuing. We really need to know quite a bit ahead of time and kind of assess some of those reasons why you may be thinking that way, and then kind of proactively have an idea of which oral option we may want to transition someone to. So again, not waiting until they decide to stop, but having an idea if we want to do the FTC TDF or FTC TAF, really being more proactive about what do we do ahead of time if that comes up. But I guess fortunately we haven't had someone to discontinue or really get that close.
Great. We do, while we're on the topic of long-acting cabotegravir for PrEP, we do have a couple of questions that have come in from our audience. The first being, do you know of any financial assistance programs for the additional labs that are needed for long-acting cabotegravir? So I'm assuming they're asking about the HIV RNA testing. And then is the injection available for PEP or post-exposure prophylaxis?
Maybe I'll speak to the latter one and only part of the first, because again, I'm not in a practice setting where it's even available on label yet. So maybe Kenric, you can speak to the program availability if you're aware of anything. But with respect to the question about PEP, I think that the short answer that I would give is no. And really it relates to the long PK tail, right? We know that although it may offer the immediate post-exposure prophylaxis that we're looking for, an agent like long-acting CAB with or without rilpivirine or any other long-acting option could probably achieve, high enough PK and have the appropriate PK/PD to prevent an HIV infection that could otherwise have occurred. But the risk is that after that, after the equivalent of the 28 days of oral PEP that we typically use, what then? And we know from a lot of experience with oral PEP that consistency of follow-up is a challenge, perhaps because so many folks who use PrEP are not already engaged in longitudinal care. So it's not surprising that many of them don't remain in care, may not always do their follow-up on time. And yet we do also know from the literature that there is a significant risk of subsequent HIV seroconversion if they're not actively engaged and started onto PrEP, for example. So I think the risk there really would be that during that long PK tail that's going to happen afterwards, that there could be a risk of resistance emerging if risk activity continues. So unless there's a creative way to actively engage such folks directly into PrEP care and keep them retained in care, I don't think that in the short term, that's likely to be a big option. But Kenric, I'd be very curious to hear about what support options might be available for that extra HIV RNA testing if folks are able to do that. And I think also worth pointing out that the frequency of testing is also an issue when we speak about the increased burden of testing, that it's recommended every 2 months to do an HIV test as opposed to every 3. So just the frequency of testing goes up as well.
Thank you, Darrell. Yeah, that's kind of a good segue into what I was going to mention. So we haven't really had great success as far as programs that are available, whether it's nationally or at the federal level, around covering the laboratory testing. We typically rely on other considerations, other pots of money that perhaps that we have. It's really a bit more non-discretionary where we can actually go in and cover the cost. So I'm not in the best position to really talk about programs that may exist to cover the lab. As we know, the manufacturers or the drug companies do a really good job of actually helping to offset the cost of the drugs themselves. But to the question, it's a great question. It's one that we wrestle with quite a bit as far as making sure that when a person is looking to start on these agents, that we can cover that cost. And as Dr. Tan mentioned, when you're going to increase frequency of testing, naturally that's going to incur a greater cost. And so that's something that we do. We try to sit down and have those discussions. And I think each agency will have perhaps different grants or other donations and other considerations that may help offset the cost of labs. But I really wish we had a better answer about as far as a program that exists. Obviously, that's something that it seems like it's on the radar of the different manufacturers. But to the best of my knowledge, it's not something that a go-to place or go-to resource for those laboratory testing. But I will say that is something that agencies should be considering ahead of time, right? Because that's the last thing you want is the cost to be a barrier, and that leads indirectly to non-adherence or people perhaps not showing up and then perhaps falling off the drug. So again, sorry I don't have a better answer for that, but I know we definitely restructured or reallocated some of our funding internally, basically hoping to address the laboratory consideration and, having an honest conversation up front about if a person's somewhat ambivalent about transitioning from the oral option to the injection, we say, well, if you do stay on the oral option, you won't test as frequently. Perhaps that would actually translate to more cost savings in that.
Great, thank you. There's another question from our audience on laboratory testing. So what are your thoughts on the at-home dried blood spot test for convenience and PrEP persistence for those that would fall out of care because they are unable to get into clinic for quarterly lab draw? Do either of you have experience with the at-home dried blood spot test?
So I can speak from my perspective. In my context, unfortunately, that particular technology isn't yet available for use by end users. Certainly, there's research in the field. There are other home testing kits that have been available for longer in the States than they have in Canada, but they're starting to become available in Canada as well. I think those certainly offer some promise, right? And if we're going to try to really be creative and push the envelope in terms of making PrEP as available as possible to as many folks as possible. Absolutely, we know that reluctance, apprehension, or just inability to make it into a healthcare setting can sometimes be a barrier to accessing PrEP care. So we absolutely need to innovate, and I would support ongoing implementation research to look at outcomes with that sort of approach. I think it's worth pointing out, though, that it's not the be all and end all of the solution, right? That there would still be a need, even if we manage to get that sort of testing done, for some other testing to be done that may or may not be always feasible to do in a home-based setting. So thorough sexually transmitted infection testing is absolutely indicated in the majority of folks who are using PrEP because the risk of HIV would be sexual for many folks, and not all of that testing may necessarily be feasible in the same way. Syphilis testing, in particular, may be a bit more challenging. Home-based urine testing, throat swabs, vaginal swabs, rectal swabs may be feasible to do and then ship into a lab promptly. Syphilis testing, again, there are some point-of-care diagnostics that are out there under study, but it can be a bit more complicated, especially with reinfection of syphilis, which we know can be a barrier. And then, of course, the limited renal testing or renal monitoring that would be recommended in this setting, certainly with the oral FRCPC-based options, could be another barrier. So I think it's part of the solution potentially in some cases, but I'm not convinced that it's necessarily going to, absolutely revolutionize how we get PrEP into the hands of as many folks as needed, unfortunately.
Thank you, Darrell. And I'll just add to your comments about, I think, another thing we will need to be mindful of, as Darrell eloquently put, like it's not going to be the end all be all, but we also need to have staff and people available to be able to talk through some of these options as we shift things more to the at-home environment. We just have, at least in our population as well, people who are just really need a bit more touches from the healthcare system, perhaps someone to call them on the phone to answer questions in real time. Yes, they're doing some of these things at home. So I think sometimes the tendency is to make things more available at home. However, we recognize, and we highlighted this today, that the literacy rates are going to vary tremendously. And so we really need to be in a position which is going to be staff time, right? Be in a position to allocate that time to answer questions as people are going through some of these at-home diagnostic procedures. So I think that's something that sometimes kind of flies under the radar, but can really be problematic if people are excited about these products at home. Even some of the more traditional options, as Darrell referred to, some of the at-home testing in the pharmacy settings or other places, we still get a lot of calls about people having questions about, making it through that process on their own. So I think the technology, as we move toward more and more advancements, we really have to make sure we have enough capacity to have that human contact and that human connection to be able to help people navigate in an at-home environment. Because that's just as vital as the technology itself, is having someone to help you to ensure that you're doing it appropriately and confident.
Great, thank you. So, Kenric, speaking of having staff to support patients, we had a question: how does a pharmacist assist with retention in terms of refills and follow-up appointments?
Oh, so great question. I think one of the big considerations that we run into sometime at the pharmacy level, it's more of a pragmatic consideration, but just having enough medication in stock, right? Those considerations are huge, particularly in the community pharmacy setting, because when people come to rely on a product, particularly something like PrEP, particularly if they continue to perceive themselves to be at risk of acquiring HIV, the last thing you will want to do is not have enough in stock to actually be able to meet that need. So again, while that may be a bit more simplistic, I think that's a really big consideration there. I think another thing that pharmacists can have a huge role in is talking about over-the-counter products, other things that people may be doing to kind of augment their health, right? But again, it should be complementary. As I alluded to an example when I was presenting about someone making the assumption that they could replace pre-exposure prophylaxis, I think being really, really clear that while some of the over-the-counter supplements and vitamins and other considerations may be helpful, right, it's really not going to supplement the need or supplant the need for PrEP. And so I think pharmacists have a really big role, and it's a captive audience. Obviously, if the person's there in the pharmacy, being able to holistically look at other regimens that they're taking and discuss PrEP in that context. But I think at a pharmacy level, definitely inventory is a big consideration. Also, making sure staff are trained to recognize prescriptions that may be for PrEP versus treatment, right? So a lot of times that's a big concern at the pharmacy level. Perhaps pharmacy technicians or others who may not have as much exposure may not recognize that prescriptions are written different ways, whether we're looking at pre-exposure prophylaxis or we're looking at a complete regimen for HIV treatment. I think those are things that pharmacists can do in their individual respects to really make sure that not only the customers or the clients are aware of PrEP and its benefits, but even the staff that they're working among, to make sure that everyone's on the same page about inventory management, about prescription recognition and what's being prescribed. And that's what you can always call provider to clarify, but it would just be great to have some of that knowledge in-house so we can kind of know, so we're not unnecessarily delaying the product getting to the customer, right? By having to call to verify something that perhaps we could have trained our staff to know about.
Great, thank you. And I know, Kenric, you had a question for Darrell about choosing between oral options.
Yeah, for certain. Yeah. So there are obviously when the product typically, and obviously pharmacist roles are evolving throughout the nation and the world, but typically our responsibility comes in when the product is already prescribed, and we're there raising awareness about it and doing some education. But I guess on the prescribing end, when you have someone in front of you and they're really kind of at a loss of whether they should do the FTC TDF or FTC TAF. I know you talked us through some of the data, but what are some of the driving factors for you in your prescribing decision around, well, I think this may be a better option for you based upon the factors and the considerations that you presented to me today?
Yeah, it's a great question, Henry. Thanks so much. And this really does come up virtually in every single PrEP patient, I think, if we're doing our jobs properly. So the first thing I'll say is that, unfortunately, one of the primary drivers in the Canadian healthcare, I should say, even in the Canadian healthcare setting where healthcare itself is universally available, unfortunately, we don't have universal pharmacare. So access to the drug itself, reimbursement of the drug itself, cost of the drug is unfortunately often the main driver. The cost of FTC TAF in my setting is still 4 times greater than TDF based or FTC TDF as PrEP. And therefore it's a non-starter in a lot of folks who don't have access to really, really good. And even those who have pretty good insurance, we talk about folks who are lucky enough to have 80%, 90% drug insurance, that 10 or 20% of drug cost is still a lot of money. And it really comes down to a very personal trade-off between, is this real but fairly modest benefit that we talked about in terms of renal and bone differences? Is it worth X number of dollars for me to pay per month? That's a tough call for a lot of folks to make that sort of decision. And typically, I'll say, in my experience, the decision sways in the direction of, sticking with a more affordable option. That being said, there are rare folks who are very privileged to have access to both with excellent insurance. And in that sort of setting, we do have the luxury of considering more clinical factors. One of the factors is the simple fact that the 2-1-1 regimen, which I must say has become much, much more, or at least increasingly popular in the last couple of years in my own practice and that of many colleagues I have here in Canada, because of COVID, in a period when people's sexual practices are changing so rapidly with lockdowns coming on and off and et cetera, maybe less so now, that became much more popular. And because 2-1-1, although off-label, as we said, is not really approved at all, there's really no evidence at this point for the use of FTC TAF on a 2-1-1 basis. We can't really confidently recommend that as an evidence-based regimen for many folks. So for folks who want the flexibility of toggling between daily PrEP, on-demand, or 2-1-1 PrEP according to their circumstances. And I would say many, not all, but many of our patients are pretty darn savvy at this point in terms of understanding their own risk. Those who desire that flexibility, it really makes FTC TDF a better option because they're empowered to make that sort of decision to some extent on their own, even in between clinician visits. If we're confident they really understand both options. And that wouldn't be as feasible for them to do if they're taking CTAF. They really would require a clinician visit every single time they wanted to consider a switch to the other modality because of it not being appropriate with FTC TAF at this time. And then finally, there are just the clinical factors. If you've got someone who's clearly got renal bone issues already, perhaps metabolic issues already as part of their comorbidity profile, that would be a consideration that you might want to lean in favor of the drug that doesn't cause those problems. One benefit that we didn't talk about on the slides today, but maybe is also worth mentioning, is that we know that tenofovir disoproxil fumarate has a little bit, interestingly, of a lipid-lowering effect. So for folks who really have an atherogenic lipid profile, you're worried about that metabolic syndrome, perhaps that's the justification for using that option in that setting, although we haven't necessarily reported or studied that extensively in the PrEP setting specifically.
Thank you very much to Dr. Tan and Dr. Ware, and thank you to our listeners for joining in. Please be sure to check back regularly for more episodes on important infectious disease topics. Thank you and have a great day.